limit that the physician was told, either through the web-based system or a phone number or whatever other system you're implementing. I mean, if the physician doesn't know based on the data available to them at that moment and they have to make a call, are they then denied payment for services they deliver?
We're concerned about that as well. And if they are told that the patient is under the limit and they move forward and suddenly someone that's been holding claims for 6 months processes claims for 3 physician visits that puts that particular Benny over the limit, they're the ones that are actually going to be at risk for having their visit denied if they don't submit their timely claims. So I think it's going to be a matter of what the physician is told through either the web-based or telephone system. I'd prefer that it be something in writing so that physician has something that says, I was told it was okay on this particular day, and can appeal.
We'd prefer that too. Thank you.
So are you saying then that the limits will not come via date of service, but date of when the claims are, so if there, because you said if there's a date of service that comes before another doctor, but the second doctor got his claim in first, then that's how you're going to be counting them?
I think somebody's going to end up with a denial. And so what they're going to need to do in those circumstances is produce either a copy of the printout from the web page that says this patient's only had 4 visits this year, and so that they are free to see the patient, or there has been some other form of communication with the fiscal intermediary system. If they're not going to use a web-based system, we should have something paper-based so that they have some evidence that they were told it was all right. And then we'll have to work out an appeal process in the event a claim is denied because the Benny has exceeded the 7-visit limit. What I want to emphasize today is that in our discussions with CMS, we have agreed that we will not implement the physician visit limit until we have a tracking mechanism in place. So our approval, we may get approval, but until that tracking mechanism is available, we will not implement the physician visit limits. We talked a little bit, yes, sir.
Is there any development already made on the tracking system, development of the web-based system? We are talking since 2011, and with the hope of getting this approved, is there any development, any work has been done to develop that system?
Not at this time. There hasn't been work on a system per se, but there has been a great deal of dialogue between the fiscal intermediary and the benefits division about how to develop a system and what that system might look like. Yes.
Is there any timeline on how long it would take to develop that system beyond the discussion level?
Not at this time.
That is something that the FI, you said, will develop, not the department, right? The tracking system that.
That's correct. It has to be. They'll need access to the claims data in order to do that, and the fiscal intermediary is the holder of that claims data for each fiscal year.
And then just another question: in the event of an audit, so say a physician office has provided care and someone is seen as being under the limit. Auditors come in and determine 1 or more visits should have counted. Things have happened in the interim. So then does the department go to claw back those reimbursements that have happened? I mean, based on valid data, right, from the existing claims, they were under the limit when they were seen, or were told they were under the limit when they were seen, and then an audit turned things around. What happens in that situation for any and all the providers who may have seen them?
I can't speak completely for audits and investigations, but this is the way I understand the process to work. So you are audited, you have an opportunity to see the audit findings and what the potential recoupment might be. You do have the opportunity to negotiate and appeal the findings of the auditors. And through that process, I'm looking at one of them, through that process, you should be able to come to some reasonable conclusion.
But that would only apply to the office that was actually audited. I'm talking about other claims that may have been paid, assuming that the limit wasn't there for other unrelated physician offices. If a patient is seeing more than one doctor, the other one was audited, and maybe they appealed and said, no, I actually think that didn't count. There's a dispute. It ends up counting. And they saw some other physician that has no idea the audit even occurred, but has since billed and collected.
Correct. So what's the impact? What's going to be the fallout to the other 7 physicians that have seen that particular patient? Yeah. At this point, I can't really tell you. You know, in that hypothetical situation, I can't say specifically. But I think that if the physicians are making a good faith attempt to identify whether or not the beneficiary has exceeded the cap and documents that and documents the reason for the exemption, whether or not they've met the 7, they should document the exemptions all the time and use the modifier so that if this type of visit is an exception or they meet the exemption, you want to make sure that that's documented so that it isn't going to impact those around you.
Exactly. I was speaking more to the visits that would count towards limit. So.
Okay.
You mentioned an appeals.
Can you use your?
I turned it off.
Okay.
You mentioned an appeals process. Where are you in the development of that process? Is there going to be stakeholder input for how that process is going to be developed?
I believe there's an existing process that is already in place for the audit process.
So it's not a different appeals
It's
process?
not different, no. We're not going to create something new. Any other questions? Okay, we're going to move forward. I want to talk a little bit about provider education, and we use our standard cadre of education materials through the Medi-Cal Provider Manual. We post articles on the Provider Bulletin on the department's website. We will be conducting webinars such as this so that we continue to communicate with the provider community. Obviously, we consider our stakeholders our partners in the education process, and we would want to work collaboratively with you to make sure that we are providing appropriate training and answering questions as they come up. So we really are dependent upon your communication with your stakeholders and you as our stakeholders. So it will be a collaborative process, and we do want to make sure that everyone understands how the system will change, how they determine who has an exception, who has an exemption, and how they bill, and what to do in the event that they have questions. Who will they call, and how will their questions be answered? So we're going to continue to develop that. But that's pretty much the standard provider education complement that we normally have, but we will have very engaged stakeholder meetings where we can work with you to communicate effectively with your constituents. Again, I want to emphasize that implementation is not going to occur until, obviously, we get approval from the Centers for Medicare and Medicaid, and after a tracking mechanism is in place for the provider community to utilize to determine whether or not a particular beneficiary has met the 7-visit limit. So at this point, that's most of the presentation that I had for you all. We've asked a couple of questions back and forth. I'm going to see if I can check to see if we have any questions online. Okay, we do. Okay, the teleconference number isn't working. Okay. Had a couple of communication and phone problems. Can you please repeat that the list that included federally qualified health centers, what was that referring to? I think we may have been referring to where these visits where we would be counting these visits. So that would be hospital, outpatient clinics, physician clinics, federally qualified health centers, rural health centers, Indian health centers, community clinics, and physician offices. Okay, for those of you that didn't push your buttons, we may need to re-ask the questions. I'm not quite sure. For the most part, I think we picked up most of them. Okay, so we've repeated the list of the federally qualified health centers, the inclusion of that list. Okay, so for those of you that have indicated that you have missed the audio portion, we will be posting the webinar and the audio portion to our website. I apologize for that inconvenience. I'm not quite sure why that happened. But the audio will be posted. You will have access to the slides and the audio. You can listen to this ad nauseum. Push your button.
Sorry if you said this already, but do you have an anticipated timeline for implementation?
It's dependent, as I mentioned earlier, upon CMS approval. Normally, once we receive CMS approval, we have 60 days post-approval to implement. In this particular situation, I do not believe that we are going to have a tracking mechanism in place by that time. It's possible, but at this point in time, I don't believe that to be the case. So we would notify the provider community that we have received CMS approval and that we are delaying implementation until we have a tracking mechanism in place. And then there would be lots and lots of notice to the provider community prior to that implementation date once a tracking mechanism is available, because we'll have to train the provider community on how to use it.
Can I ask sort of a follow-up? I guess what I'm wondering is if there's a savings amount that you all are associating with this, and if we'll see that in the January budget for 13-14.
I can't speak to that specifically, but I can look into that, and if you'll leave your name, we can get back to you about that.
Question I have is, since we all know that CMS has to approve all the SPAs, and there are times when CMS does not all the time, they don't all the time approve those SPAs.
Is that true? I'm teasing.
At least one or a couple of things have happened, so I don't know. I guess you're wishing that it's approved, I guess. So I guess there's a lot of back and forth discussion has gone into this SPA, and you have made some progress in coming up with the changes and tracking mechanism. So it's pretty much, after it's submitted with the way CMS wants it, so it's pretty much a done deal from CMS point. They have already they are leaning towards approving it with the changes requested.
I can't speak for CMS. And we've been dialoguing back and forth. There have been a number of questions. We've done quite a bit of research. We've reviewed claims data and responded to a variety of different questions. We're still answering questions today. So I really can't tell you what the intention is of CMS. We are negotiating in good faith, and we certainly hope that we can garner approval.
So one bigger question here is that since next year onwards, managed care is going to cover all the counties.
Correct.
So how it impacts, I mean, is it required to have 7 visits even after managed care comes and accountable care health,
It applies to those individuals, those beneficiaries that will remain in fee-for-service. There will be a population that is going to remain in the fee-for-service arena that will not be in that will not enroll in a managed care plan.
So those will be after 2013 July 1st. Only those would be the potential providers who will get affected.
Correct.